just a minute better. Share the screen for a longer time. No? So I would like to make you understand few things in the skull bone. See, this is norma verticalis, what you are seeing. Norma verticalis is when you see the skull from the superior aspect. So number one, whatever is written is frontal bone, and number two on each side is written is two parietal bones, and behind we have occipital bone. Okay, then here what are the various sutures you are finding? What are these two foraminae? Parietal foramen, isn't it? So here you have sagittal suture, coronal suture, and lambdoid suture. Okay. Then see, this is also lambdoid. Okay. This is sagittal suture. Okay. So and here these are actually extra bones. So why I'm showing you these images, because the attachments of the scalp will go to these areas. So this is completely occipital bone. On the occipital bone you have, this is external occipital protuberance. This area which is more prominent is external occipital protuberance. From the external occipital protuberance we have certain lines which are called as nuchal lines. So we have superior, highest nuchal line we have. Okay. So above, below this highest nuchal line we have superior nuchal line and inferior nuchal line. Okay. So the various things what you are coming across now are, see, this is coronal suture, this is sagittal suture, this is lambdoid suture, frontal bone, two parietal bone, these are parietal eminences. Okay, this is occipital bone. Okay, why I'm letting you understand all these, because if you understand these names you will know the attachments of scalp. Okay, now let us see. So scalp has how many layers? See, scalp is soft tissue covering which is covering the vault of the skull. So anteriorly the scalp is extending up to the eyebrows. You call these as superciliary arches. Posteriorly, just now I have shown you in the skull bone, behind superior nuchal lines. So posteriorly it is attached. From here it goes like this and it is attached to superior nuchal lines. Laterally here we have superior temporal lines, because these are two temporal bones. Okay. So see, these are superciliary arches, eyebrows, and this is our superior temporal line, and the scalp is moving like this. Okay, from here you can see it goes up to superior nuchal line. Okay, this is the complete extent of scalp. Okay, then so you can see this green area is the frontal area. Here you have temporal area. This is all parietal bones region. This is the occipital bone region. You can see the extent. Superciliary arches, from here it has started and up to superior nuchal line and superior temporal line. Okay. Now scalp is named as SCALP. So for our easy remembrance, we are just dividing it like to the names, like S is standing for skin, C is standing for connective tissue, that is the superficial fascia, A is standing for aponeurosis, that is epicranial aponeurosis, also called as Galea aponeurotica. Okay, then L is actually loose areolar tissue, and the fifth layer we have is just below this, just above the skull bone, thin membrane, that is pericranium. SCALP, skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. Okay, one by one, if you observe, this is skin. If you observe the skin of scalp and the skin of other areas of our body, the scalp has lot of hair. It has many sebaceous glands, sweat glands. Okay, below which we have connective tissue. Okay, then aponeurosis is quite thick. Okay, it will receive the insertion of two muscles, From the front we have frontalis, from behind we have occipitalis. Together you call it as occipitofrontalis. This is our skull bone. Covering the skull bone, the thin membrane is periosteum. Okay, beta? So like that, you see here skin. Let us describe each part now. When you talk about skin, the skin is very thick and hairy, except for forehead. In the forehead region, we do not have hair. Rest of the skin of the scalp has lot of hair, and the skin is firmly adherent to the third layer, that is epicranial aponeurosis, by dense connective tissue of superficial fascia. That means this is skin and this is superficial fascia and this is Galea aponeurotica. You cannot actually separate these three layers when you are doing dissection. It comes as a single flap. Why does it happen so? Because all these three layers are very much closely adherent to each other via the fibers which are moving from the skin to the third layer, that is epicranial aponeurosis. Thin See, firmly adherent to third layer epicranial aponeurosis by dense connective tissue of second layer, that is superficial fascia. So skin has lot of hair, it has lot of hair follicles and it has sebaceous glands. See, though we take head bath, within 1 or 2 days again you see our skin, our hair become very much oily. Why is it so? Because in the scalp we have lot of oil glands which are called as sebaceous glands. These sebaceous glands are the sites for sebaceous cysts. Okay, if there is any infection in the sebaceous gland, you call it as sebaceous cyst. And if you see in the summer, we sweat a lot. Even in the scalp, you see so much of sweat coming out. That means what? The skin also of the scalp has like many sweat glands. Okay. So once you are done with the skin, then we have second layer, that is the superficial fascia. We can also use the word connective tissue in order to make that like mnemonic SCALP. Okay, so that superficial fascia or the connective tissue, this one which is shown like this. So this superficial fascia, it has like a dense fibrous connective tissue that firmly binds skin to the next layer, that is epicranial aponeurosis. And within this epicranial aponeurosis, I said we have two muscles, occipitalis and frontalis. Together we call it as occipitofrontalis. Okay. Now the fibrous septae will be there which divide this layer into small pockets. You can see these containing all yellow, 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 yellow. That means these are all fat lobules. And thin septae will be there which are moving from the skin to the epicranial aponeurosis, which divide the connective tissue region into compartments. All these compartments are filled with fat. Okay, that is. Then we will see lot of blood vessels and nerves of the scalp lie in this layer, second layer. Okay, and they enter it from below to the periphery. We will see this. So walls of the vessels, can you see blood vessels are seen in this second layer? That is the connective tissue. So the walls, that means tunica adventitia of the blood vessels are adherent to this surrounding fibrous tissue. Hence, when these blood vessels are cut, usually if any capillary is cut in any part of our body, we know it usually closes and the bleeding is arrested by a natural mechanism of vasoconstriction. But unfortunately here, the blood vessel wall, tunica adventitia, has connection with surrounding fibrous connective tissue. Hence, when blood vessels are cut, they are not allowed to get constricted. They remain wide open and the bleeding continues. Okay, that's why if there is any injury in the scalp, it will lead to heavy bleeding. Okay, heavy bleeding. So it is stopped by pressing against underlying bone. That means in order to stop the profuse bleeding in the scalp, we are supposed to apply pressure from outside. Okay, that is. Now, what is the third layer? We have epicranial aponeurosis, also called as Galea aponeurotica. So, in this epicranial aponeurosis, we have muscle occipitofrontalis. From the anterior region, we have frontal belly. From posterior region, we have occipital belly. Okay. So, Galea in the Latin terminology, it means helmet. Okay. So greater part is formed by aponeurosis, that is aponeurotic layer. Then we have fourth layer, that is loose areolar tissue. Okay. So see, all the three layers are actually freely moving over this loose areolar tissue. Okay, made up of, now this layer is loose areolar tissue, this one XXXXS is drawn, no, it has a lot of loose connective tissue. So it's a natural plane of cleavage during craniotomy. Craniotomy means when you are planning to do any surgical procedure. In case of brain tumor, we generally use this plane to enter into the cranial cavity. So if you observe, I told you these are the five layers, no, skin, then we have the connective tissue, okay, then we have the galea aponeurotica, then we have loose areolar tissue and epicranium, like pericranium. So if you observe below pericranium we have skull bone, and below skull bone we have the meninges covering the brain. Okay, what are the meninges covering the brain? We have dura mater, arachnoid matter, and pia mater. So within the dura mater, within the split of dura mater, we have dural venous sinuses. Dural venous sinuses. Below the skull bone, this is our skull bone, we have dura mater. Dura mater is splitting to enclose venous blood. So this venous blood has communication with the skin of the scalp, and these communicating channels are called as emissary vein. I have shown you the parietal foramen, no, previously. Through that parietal foramen you will see the emissary veins are actually coming out. Okay, just a minute. Emissary veins are the veins which are moving from the intracranial cavity to outside. Okay, they are, see, traversed by emissary veins connecting veins in second layer of scalp with intracranial dural venous sinuses. Okay. So this is one slide which is showing us dissection, of course, which is not much very clear. I'll show you at the end like various pictures related to dissection. Also, pericranium. This is the outermost thin layer which is covering the bone of the scalp. Periosteum of the bones of the vault of the skull, that is pericranium. So it is loosely attached to the bones. It can be easily stripped when you are doing dissection. Okay, so sutures, but along the sutures, just now when I was starting, when I started my lecture, I have shown you coronal suture, sagittal suture, and also lambdoid suture. So all these areas you will see this is actually firmly adherent in that particular point. Okay, now we are talking about the muscles which are present in the third layer. What is the muscle? What is the third layer? We have epicranial aponeurosis, also called as galea aponeurotica. From the front we have frontal bellies, and from behind we have occipital belly. So frontal belly is the frontalis muscle, occipital belly is the occipitalis muscle. Together you call it as occipitofrontalis. So frontal belly, it is coming, origin is skin from here and subcutaneous tissue over the eyebrows and root of the nose. That means whole of this plane is giving origin to the frontal part of occipitofrontalis. Just now you have seen the muscle fibers are just running backwards and they are getting inserted into epicranial aponeurosis. This frontal belly, it has no bony attachments. It is directly coming from the skin of forehead and it is going and getting merged with epicranial aponeurosis. Okay, so you need not remember the remaining points. This is not required. Only the skin of the eyebrows and at the root of the nose it starts and it is getting inserted in the epicranial aponeurosis. These are the frontal bellies. Okay, see, this is our frontalis muscle and this is orbicularis oculi, procerus, and the remaining other muscles. The muscle fibers of actually frontalis are merging with the other muscles, not required. Now see here, there is one clinical significance I will tell you at this point. See, I told you the blood vessels are bleeding if there is any injury to the scalp. So in such case, the blood vessels are not retracting. So because frontalis muscle has no bony attachment, if there is any bleeding in the scalp, the blood is slipping down and it is getting collected in the eyelids. Okay, because the muscle has no bony attachments, hence it easily slips down towards the gravity, leading to black eye. I will show you the slide of black eye because we are discussing about frontalis. Just to make you understand, I told you. Then we have Occipital belly. Occipital belly, just now I have shown you superior nuchal lines. So that is, they are found behind the skull bone. From the occipital bone, we have superior nuchal lines from where you will see the occipital bellies are coming, and then you will see they are moving upwards and they get inserted into epicranial aponeurosis. And you have also seen like these two bellies are separated widely. Okay, there is, this is one belly coming from superior nuchal line, this is one more belly coming from superior nuchal line, both are coming and getting inserted in epicranial aponeurosis. Okay, then, so nerve supply of these muscles, occipital belly is receiving from posterior auricular branch of facial nerve, frontal belly is receiving nerve supply from temporal branch of facial nerve. Okay, you can see this is the nerve supply, this is frontal belly temporal branch of facial nerve, this is occipital belly posterior auricular branch of facial nerve. Now what these muscles will do, frontal and occipital bellies, alternate contraction of frontal and occipital bellies move the scalp forwards and backwards. That means you are able to do frowning movements. You are finding certain horizontal lines developing. When you say, I don't know, or something, we generally do certain facial expressions, which is like when the muscle is contracting from above, it raises eyebrows as in surprise. Okay. So when this is acting from below, it produces transverse wrinkles on forehead as in fright. Okay. So this I will show you. See, black eye I said. So what is black eye? I told you the frontal belly of occipitofrontalis muscle has no bony attachments. Hence, in road traffic accident, what happens? And we also know the blood vessels are tunica adventitia is going and attaching to the connective tissue of the second layer. Hence, if there is any road traffic accident or any injury, what happens? The blood is just slipping down and getting collected in the eyelid, leading to black eye. Okay. So dangerous area of scalp, the layer of loose areolar tissue, okay, that is the fourth layer is called as dangerous area because blood and pus freely tend to collect. It is very loose area, no? You can easily actually move your scalp over the fourth layer. So whatever infection is there, pus is there, blood is there, it gets easily collected over that fourth layer. Hence, fourth layer of the scalp is called as dangerous area. Okay. If pus collects in this layer, the infection may travel via emissory veins into dural venous sinuses. That means infections of the scalp via emissory veins, they can enter into cranial cavity. That means inside the brain, the infection can reach via emissory veins. So if the blood is clotting in blood vessels, I have already told you the word thrombosis, and if it is big clot, it may also result in death, which may be fatal. Okay, cephalohematoma is the collection of blood beta. Okay, so just below the periosteum, if you see the collection of blood, you call it as cephalohematoma. Whereas extradural hemorrhage, this is our skull bone, yellow in color. Above the dura mater, if you see the collection of blood, you call it as extradural hemorrhage. Okay, cephalohematoma is collection of blood below periosteum. Okay, so this is cephalohematoma. Caput succedaneum is a condition where you will see if the baby is exposed to prolonged labor. Okay, if the labor was prolonged, then you will see collection of fluid in the layers of scalp, and this automatically will regress within 2 to 3 days. There is nothing to worry. So that condition is called as caput succedaneum. Caput succedaneum. It is just subcutaneous edema. Okay, because there was a prolonged delivery. Okay, automatically after few days the edema will subside. Okay, that condition is caput succedaneum. Okay, now coming to the nerve supply of the scalp. So we have like four sensory nerves and one motor nerve in front of the ear. Similarly, four sensory nerves and one motor nerve behind the ear. So we generally divide the nerve supply like in front of the pinna and behind the pinna. So in front of the pinna, I want everybody to draw this diagram. The four sensory nerves are, just name them. We have supratrochlear, then supraorbital, then zygomaticotemporal and auriculotemporal. Okay, all these are the branches of trigeminal nerve. If you remember me telling, trigeminal nerve is giving sensory supply to the face. Similarly, the same trigeminal nerve is giving sensory supply to scalp also via these four nerves in front of the pinna. Behind the pinna, the sensory nerve supply comes from cervical plexus. Okay, network of C1, C2, C3. Okay, so we have, what are the names of nerves? We have great auricular, lesser occipital, greater occipital, and third occipital. Okay, this is behind the auricle, great auricular, lesser occipital, greater occipital, and third occipital. Okay, then uh, see, motor supply, I gave you two nerves, auricular branch of facial, this one, temporal branch of facial and posterior branch of facial. These are the two motor nerves. In front of the pinna, we have temporal branch of facial. Behind the pinna, we have posterior branch of facial. That's how overall, in front of the pinna, we have five nerves. Behind the pinna also, we have five nerves you have to list out. Four sensory, one motor, four sensory, one motor. Motor is branch of facial. Okay. Temporal branch and posterior auricular branch are the branches of facial. Now see here, in front of the pinna, we have certain blood vessels. Now again, when you talk about the blood supply, we have to give the names of the blood vessels. Okay. So here, again you draw a rough diagram of the skull bone. Again, you write few blood vessels in front of the pinna and behind. So front of the pinna, the name of arteries and nerves are same. Supratrochlear artery, supraorbital artery. Okay, then we have superficial temporal artery. Supratrochlear and supraorbital arteries are the branches of internal carotid artery. We saw internal carotid artery when we were doing circle of Willis. That means internal carotid artery is actually supplying inside the brain, not outside. See here, beta. So supratrochlear, supraorbital are the branches of internal carotid artery, which basically supplies the brain. Whereas the other arteries, whatever are named here, like superficial temporal artery, posterior auricular artery, occipital artery, these are the branches of external carotid artery. So in the scalp, we find the anastomosis of external carotid artery with internal carotid artery. Okay, so internal carotid artery actually supplies ophthalmic artery. That ophthalmic artery branches only will come and enter into the scalp via orbit like this. Okay, that's how it gets entry. The internal carotid artery branches are supratrochlear, supraorbital. Remaining all are external carotid. You need not draw ditto same diagram, nothing like that. Main arteries and you draw some XXX, this just join them. Okay, show the anastomosis. Okay, that's it. And you draw diagram and you write in your own words. Okay, here also arterial supply. In front of the pinna, you give the list. Supratrochlear, supraorbital, superficial temporal. Behind we have posterior auricular, occipital. That's it, better. Okay, so it's given in the form of table. Similarly, you can also write in the form of table. Supratrochlear, supraorbital, I told you these are the branches of internal carotid. Rest all are the branches of external carotid. Okay, so here you are finding there is an anastomotic network of external and internal carotid artery. Okay, venous drainage. See here, the venous drainage we have to study. Same names, veins, concentrate. See, venous drainage of face and venous drainage of scalp is same thing. Listen carefully. We have here supratrochlear vein, supraorbital vein. Both of these veins are draining into facial vein. This one, beta, angular vein first. From the angular vein, this whole vein is actually named as facial vein. Okay, this whole vein. Okay, the facial vein is draining into common facial vein The common facial vein is draining into internal jugular vein. Now, if you observe, this facial vein is also receiving tributaries via from cavernous sinus. See, this is actually called as pterygoid plexus of veins. So pterygoid plexus of veins and emissory veins are connected via cavernous sinus, are connected via emissory veins. Cavernous sinus itself we are going to discuss as an essay very shortly. It is an essay question. It's a part of dural venous sinus which we see inside the brain. Okay. So there is a connection between a network of veins which we have here, that is pterygoid plexus of veins, with the vein of brain, that is cavernous sinus, via emissory vein. So here we have this deep facial vein which is actually draining into the facial vein. Okay, so that means cavernous sinus, emissory vein, pterygoid plexus of vein, deep facial vein, that is also draining into facial vein. This particular part of venous network we have done when we were doing parotid gland. If you remember me telling, we have there retromandibular vein. Retromandibular vein will have anterior division and posterior division. So anterior division is draining into facial vein. Posterior division is draining with the posterior auricular vein. This we discussed twice. When we were doing external jugular vein also, I told you. When we did parotid, when we did external jugular, I told you the posterior division of retromandibular vein and posterior auricular vein, both of them are joining and draining in the external jugular vein. External jugular vein drains into subclavian. To know more tributaries of our retromandibular vein, in the parotid, I told you, we have superficial temporal vein and occipital vein and maxillary vein draining into retromandibular vein. You just practice this diagram and write your own sentences. This will help you to write the venous drainage of scalp and also face. Let me repeat again. We have supratrochlear vein, supraorbital vein draining into angular vein. This whole thing is facial vein. Facial vein is draining into common facial vein. Common facial vein is draining into internal jugular. Over. Then this facial vein is also receiving the venous network, cavernous sinus, emissory vein, pterygoid plexus of veins, and the deep facial vein. Okay. Then we have to talk about retromandibular vein. Anterior division is draining into facial, posterior division is joining the posterior auricular, draining into external jugular vein. External jugular vein drains into subclavian. Into the retromandibular, we have maxillary vein draining, superficial temporal vein draining, occipital vein draining. That's it. That is the venous drainage of scalp. Okay. So emissory veins, what are, sometimes you will get 3 marks question, emissory veins. So these are the veins connecting veins outside the cranium with the intracranial dural venous sinuses passing through foramina in cranium. Like these are the parietal foramen. Through this parietal foramen, the emissory veins will successfully enter into the inside the skull and it will join the dural venous sinuses. Okay. This is the parietal foramen which I have shown you. So you call it as parietal emissory vein. Okay. So it passes through parietal foramen and the emissory vein joins superior sagittal sinus. Dural venous sinuses I will explain you one day. Nothing to worry. So here in the mastoid bone, actually this is the mastoid area. Here we have mastoid foramen. Through the mastoid foramen, we have mastoid emissory veins passing. Okay, and it communicates here at this region. Correspondingly inside the skull bone, we have sigmoid sinus. So mastoid emissory vein joins with sigmoid sinus. Parietal emissory veins joins with superior sagittal sinus. Okay, so emissory veins are joining the veins of scalp with the dural venous sinuses inside the skull bone. Hence there is a risk of transferring the infection from the scalp to the brain. Coming to the lymphatic drainage of scalp, see here, this is ear. In front of the ear, the lymphatics are going to preauricular group of lymph nodes, also called as parotid group of lymph nodes. Behind the ear, we have occipital nodes, also called as, like, we also have certain group of posterior auricular lymph nodes. Okay, hope you understood this scalp. Okay, so Actually, I told you I will show you little more pictures about scalp, right? So I hope you are seeing some other PowerPoint. This is little in this. This is the way we dissect in the cadaver, right? So once you keep markings, you will start reflecting the skin. Okay. So many layers already have shown you. First we have skin, then we have this connective tissue. Okay. So after that we have epicranial aponeurosis, third layer, Galea aponeurotica. Okay. Then what is the muscle? I said getting inserted occipitalis and frontalis. Okay, the fourth layer is loose areolar tissue, which I said as dangerous area of face, dangerous area of scalp. The last layer, which is close to the skull bone, is periosteum. Okay, the name of this muscle is occipitofrontalis. You can see the action. Okay, this is the frontalis muscle, frontal bellies of occipitofrontalis. They are actually raising the eyebrows for the expression of surprise or horror. Okay, here actually you can draw this type of picture also. In one picture itself, you can show the nerve supply and also the blood supply. Okay, some clinical pictures also I'll show you, like black eye and all. See, scalp wounds, they tend to gape like this because so much of connective tissue, fibrous strands are there. We need to suture it. Okay, this is cephalohematoma. This is black eye. Okay, so that's it. And the next, I will take you to ulnar nerve. So meanwhile, keep studying scalp. Don't waste time.